Good morning, everyone. Good afternoon, good evening. Just wanted to make an audio check. Can you hear me well?
All good, thank you.
So my name is Alejandro Kane. I am the head of medical vaccines at Pfizer, and it's my honor and pleasure to be here today to introduce this webinar, who is being run by Dr. Ruxandra Draghia-Akli. As you read in her CV, she currently serves as a chair of INTREPID Alliance Scientific Advisory Board, and through her career, she contributed to the discovery, development, and commercialization of several novel products. She previously served as an executive vice president and head of research and development at Novavax. She also played a role in Johnson & Johnson and Merck, developing many vaccines and tools that were helping, particularly developing countries to be prepared to deal with threats like Ebola, human papillomavirus, dengue, coronaviruses, and tuberculosis and HIV. So today, Ruxandra will provide an overview of something that is very close to all of us that work in the vaccines arena, which is vaccine confidence. And she will touch base on the evolving landscape of the vaccine confidence, the factors that contributed to the vaccine hesitancy, and the action that scientists, medical community, and other stakeholders can take to help rebuild trust and support vaccine uptake. Ruxandra, I promise you I will use only a couple of minutes, so thank you very much for joining us today, and now I will turn the session over to you. Thank you.
Thank you so much, Al, and good morning, good afternoon, good evening, everyone. Thank you for making the time for this presentation, and I would like to again thank the International Society for Vaccines for inviting me to give this talk. So I'm Ruxandra Draghia. I'm the chair of the Scientific Advisory Board of INTREPID Alliance. For those who don't know, this is a non-profit organization focused on antiviral research. But today I will discuss another aspect of the ecosystem, and over the next 40 minutes or so, we'll walk through a history of vaccine confidence and hesitancy, look at the forces shaping trust right now in 2026, and then talk about what it will probably take to rebuild confidence, not just simply vaccines, but really, and supply them, but really rebuild belief in them. This isn't a talk about whether vaccines work. The science on that is settled, and we'll look at the data. It is not a talk about various vaccine platforms that have been a lot in the news, or the access to vaccines, or diseases where we do not have yet a vaccine, such as HIV or hepatitis C, where the public health intervention is based on effective treatments. This is a talk about trust, how it's won, how it's lost, and why, and how today in 2026, it is being tested again in ways we haven't seen in a generation. So can we go please to the next slide? And I'd like to start with a baseline because it's easy to lose sight of it in a conversation about confidence or the lack thereof. Vaccines are by any measure one of the greatest success stories of modern medicine. More than 30 infectious diseases can now be prevented by vaccination, and the WHO estimates that immunization saves somewhere between 2 and 3 million lives every single year. And when you compare mortality from smallpox, polio, diphtheria today against the time when their respective vaccines have been introduced, you're looking to close to 100% decline. Even measles and mumps are down more than 99% from their historical baseline. But here's the issue I want to anchor the entire talk on. These gains are built on a simple foundation, and confidence in vaccines is not guaranteed. It has been contested since the very first vaccination campaigns. Next slide, please. Before we go into the history, let's ground ourselves in where global coverage stands today. Measles first dose is about 84% globally, second dose 77%. The full DTP3 dose series, 85%. So none of these numbers reach the threshold you need for herd immunity. Take the 95% for measles, as you all know, is one of the most contagious diseases we vaccinate against. So it's our canary in the coal mine. And I'll take it as an example throughout my presentation. The consequences of that gap are already visible. 57 countries reported major or disruptive measles outbreak in 25, and 13.5 million children received 0 vaccine doses in their first year of life. The good news, vaccines have saved over 150 million lives in the last 50 years. So we are not starting from failure. We are actually starting from a system under strain. So now going to the next slide, hesitancy actually is as old as vaccination itself. I think that it's generally important to understand that what we are living through is not new. It's a very old pattern, wearing new clothes. So 1721, Mather and Bollystone tried smallpox inoculation in Boston, and the public reaction is outrage. Someone literally threw an incendiary device at Mahler's house. Take it to 1796, Jenner shows that cowpox protects against smallpox, but religious objectors call it unnatural. Some genuinely fear it will give people bovine traits. The cartoons of the time are very saying. Taking a step forward, in the last decades of the 19th century, the UK makes smallpox vaccination compulsory, triggering mass resistance. The Lancaster Anti-Vaccination League forms, and for an example, a march in 1885 drew somewhere between 80 and 100,000 protesters. By the late 1800s and into the 1900s, organized anti-vaccination leagues are forming all across Europe and the US, built around bodily autonomy, distrust of government mandates, and religious or moral objections. And I would like to emphasize this last sentence again, because those are essentially the same arguments we hear today. The costumes have changed. The core anxieties haven't. So moving to the next slide and fast forward to the modern era, you see the same pattern repeated 3 times, almost like a template. First, a UK study links wholesale pertussis vaccine to neurological injury. Media coverage is intense. UK coverage drops from around 80% to 30%, and pertussis cases surge into the tens of thousands. Larger studies, obviously later on, failed to confirm the link, but by then the damage and the advocacy infrastructure is built, outlasting science. Next, maybe probably the best. Now, Andrew Wakefield publishes a 12-patient case series in The Lancet, suggesting a link between the MMR vaccine and autism. That study is later found to be fraudulent, is retracted in 2010, and Wakefield loses his medical license. But yet the claim still flourishes today, nearly 3 decades later. Third example is the HPV vaccine rollout, which drew objections framed around adolescent sexuality, parents' rights, despite strong safety and efficacy data, and it slows uptake across the globe. The pattern across all 3, and I'm going to come back to a couple of these examples, is the same. A single flawed or fraudulent claim amplified by the media, which outlives its scientific rebuttal. That's the mechanism we are still fighting today. So let's go to the next slide and spend a moment on a very concrete case study of that mechanism, because it shows how a single person influence can reshape policy in a state. So after losing his license in 2010, as most of you know, Wakefield relocates to Austin, Texas, where he found a receptive audience among vaccine skeptical parents. And through 2015 to 2018 period, he promoted the film Vaxxed and amplifies the voice of groups like Texans for Vaccine Choice. And in parallel, exemption-friendly legislation spreads through the state. The result, an almost 2,000% increase in the rate of Texas school children exempted from at least one vaccine. In parts of Austin and North Texas, private school exemptions rate are as high as 20 to 40%. That's way under the coverage you need for community protection. So one discredited doctor, one adoptive state, and really a generation of eroded coverage. That's how durable this kind of misinformation can be once it finds fertile ground. Let's take another example. Next slide, please. And I think that this one is genuinely the most useful one in the deck because it isolates the one variable that actually matters, not whether a scare will happen or can happen, but how the system responds to it. So all three countries, UK, Ireland, Japan, rolled out school-based HPV vaccination around the same time frame, and all three hit a media-driven safety scare. The outcomes were completely different. So in the UK, unfortunately, a school girl dies hours after a vaccine dose at school, but the coroner's finding, which were an undiagnosed tumor, is communicated within days. Only one vaccine batch is quarantined, not the entire program. The result is really no lasting impact. UK coverage held around 84 to 90%, and the recovery time was days. In Ireland, in the 2015 timeframe, advocacy groups built a social media campaign of personal injury stories, and the response is very slow at first. Coverage falls from 87% down to 51%. But starting in 2017, the Health Service Executive builds a 35 plus member vaccination alliance and runs a sustained human personal narrative campaign fronted by a wonderful patient advocate, Laura Brennan. If you haven't seen her, please do, who shared her own cervical cancer story. And coverage climbs back to about 70% by 2019. The recovery time in this circumstance was about 3 to 4 years once a coordinated response is in place. Japan, 2013, media reports allege adverse effects just 2 months into a proactive recommendation. The Ministry of Health suspends the recommendation and keep it suspended for 8.5 years, despite repeated safety review finding no causal link. And the coverage crashes from about 70% to under 1%. The recommendation resumes in 2022, but uptake is still critically low. The lesson, I think, is very stark. Fast, transparent, proportionate handling can prevent the crisis entirely. A delayed but eventually coordinated response can result in a recovery in a specific period of time, a few years in this case, yeah. But suspending a policy can cost the better part of a decade and has an effect on a generation that could have been protected. And why is this important? I think we can go to the next slide and we look what confidence sustained over time buys you. And Australia is the best case study in the world for this. So Australia launched the first national HPV program in 2007. It was extended to boys in 2013. And look at the cervical cancer incidence in women aged 25 to 29. The first cohort vaccinated as girls, now in their late 20s, in early 30s. It falls from 9.3 cases per 100,000 to 0.5 in 2025. That's roughly a 95% decline in that age group. And for instance, in 21, Australia recorded 0 cervical cancer cases in women under 25. One caution on this slide, which is that vaccine coverage for girls by the age of 15 peaked at about 85.7% in 2020 and has since gone down to 81%. So the lesson here is that success is not self-sustaining. It needs active maintenance. And if we can go to the next slide and zoom out from Australia to the whole world, the same story scales up. What started as one country's program is now part of national immunization schedules in 164 countries as of January 26, up from 149 2 years earlier, 117 5 years ago. Globally, the cervical cancer incidence is down 15%, mortality down 32%, but there are still new cervical cancer cases worldwide and deaths, so it's a lot of work left, but the trend is unambiguous. And I would argue that this is what confidence and leadership produces at scale over 2 decades. Worth holding on that idea as a turn to another part of the story. The next slide is linked to something that is closer to us, is COVID-19, that didn't create vaccine hesitancy, but is accelerated nearly every dynamic we've talked about all at once. So unprecedented speed. The mRNA vaccines were developed and authorized in under a year, almost a year. No one recalled the 25 previous years of work on mRNA, which enables this incredible achievement. Everyone focused on potential risks, real or not. The mandates, employer, school, and travel mandates provoke a strong civil liberties backlash, reframing actually the vaccination itself as a proxy for government outreach rather than a health decision protected not only the individual but the community. Then came the politicization. Vaccination status became a marker of political identity, not only in the US, elsewhere, sorting attitudes by party in a way we haven't seen with any prior vaccine. And most critically, I think, the trust built during the emergency part, when the COVID-19 death toll had reached approximately 100,000 deaths within the first 100 days, maybe more, alongside with more than 1.3 million confirmed infections worldwide. Everyone cherished and cheered the vaccine development, but it did not hold. But by 2024, 2026, trust in health institutions and in routine childhood vaccine had fallen way below. That's the accelerant effect. COVID didn't create its own hesitancy, but it spilled over and eroded confidence in the entire childhood schedule. Let's go to the next slide and look specifically at the US, because the partisan split here is dramatic. Trust in the CDC health recommendation by party are a good example. So Democrats went from 92% in 25 to 77% in 26. Independents, 63 to 34. Actually, Republicans rose for 47 to 67%. But the overall trust in the CDC recommendation sits at 50%, a 27-point drop from the year before. And only 57% of the public says now that the childhood vaccines are very safe, down from 70%. And here is the detail I think matters most, and we will talk a little bit later again about it. Trust in state and local health agencies sits at 67 to 70%, so it's well above the trust in the CDC or the FDA, which is, 53%. So now, for the first time, proximity is now beating hierarchy. We'll come back to what that implies for messaging strategy. Talking about messaging, let's go to the next slide. And indeed, some of that CDC trust decline tracks directly against a genuinely turbulent policy year. So in June 25, all 17 sitting members of the CDC Vaccine Advisory Committee, the ACIP, were removed, replaced. In December, the CDC drops a routine newborn hepatitis B vaccination recommendation. In January, the childhood schedule is cut from 17 to 11 universally recommended diseases, but this bypassing the usual ACIP review process. And then in June, the HHS issued a new ACIP charter adding vaccine skeptical groups as non-voting liaisons. So here's why it matters for confidence, regardless of where you land on the substantive merits of any individual decision. These very rapid, court-contested changes to a schedule built over 30 years create the appearance of instability at the exact moment public trust is already strained. It becomes generally hard for parents, for clinicians alike, to know which recommendation currently stands and what they should follow. So let's go to the next slide and look at the consequences that are hard to argue with because they're hard number, not a sentiment survey. So the US confirmed measles cases stand at already 2,295. That was a number in July of this year. The kindergarten MMR coverage have fallen below the 95% threshold, and the CDC estimates now that the gap left roughly almost 300,000 kindergartners unprotected in a single school year, so 24 to 25. 93% of measles cases are in people who are not vaccinated. The US is actually expected to have its measles elimination status formally reviewed later this year, a status that the country has held since 2000. The next slide will show that, in fact, that erosion is not only a US story, and it isn't abstract. Look, for instance, at Austria and Romania. In January of 26, the WHO announced that 6 European countries have lost their measles-free status. And in a multi-country misinformation survey, global confidence in health decisions fell from 61% in 2025 to 51% in 26. So a 10-point gap in a single year. So I would also want to point out a kind of a mechanical point, which is that trust erosion is compounding. Once coverage drops below herd immunity threshold, outbreaks become the visible symptoms of what was until then truly an invisible confidence problem. By the time you see the outbreak, the trust has already gone. So can we go to the next slide? Because I think that the image today is quite saying. And in some parts of the world, more than 20 to 30% of respondents doubt that vaccines are effective. A very far cry from 10 years ago. So the same survey in 2015 showed that more than 90% of responders agreed that vaccines are effective. And 87% of global respondents, they agreed that the vaccines are safe. The difference is staggering. Let's go to the next slide. And I just want to mention here very briefly that globally we have the 13.5 million zero-dose children in 25, but unfortunately more than half of all zero-dose children live in fragile or conflict-affected settings, but coverage is also sliding in some higher income countries, where is this hesitancy, not access, that is the barrier. Next slide is making another more subtle point, which is an important methodological insight, if one wishes to call it like that. A reassuring national average can hide exactly where the risk is. I mentioned that the US kindergarten MMR coverage nationally sits at 93%. But look at this graph that ranges from 79% in the lowest state up to 98% in the highest. 39 of the 50 states now fall below the 95% threshold. As an example, I lived in Texas, so this is why I'm taking Texas as an example many times. Yeah, 55% of Texas counties fell below it. So the average is diagnose the country, but only local data can locate the risk. So outbreaks don't start at the national average, they start in unprotected communities. Going to the next slide, and I would like to take an international example that to drive that local variation points, because the Democratic Republic of the Congo, it's a very interesting case study, and it shows that it can flip in very surprising directions. So for instance, the mpox vaccination acceptance nationally was 61%, but studies, and the data is partial, so we need to take it very carefully, ranged from about 20% to over 80% by province. COVID-19, from about a national average about 56%, ranging from 40 to over 84% per province. And the Ebola vaccination in outbreak zone studies ranged from 10 to 99%, depending on when and where you measure it. And the direction of the urban-rural gap flips by disease. So for instance, rural area showed higher mpox acceptance, but urban area showed higher Ebola vaccine acceptance during the 2018-2020 outbreak. So when we are talking about the attitudes to vaccine, we are not talking about a single attitude towards vaccines. There are dozens of local attitudes, and sometimes they move independently, and they move independently in function of the disease. I would like to also note to the point that I've made earlier about the overarching vaccine confidence in 2015 and more recently, I've put there a statement taken from the Vaccine Confidence Project. The agreement with vaccines are compatible with my beliefs that fell actually in the DRC between 2015, in the midst of the largest Ebola outbreak in West Africa, to 2020, the COVID era. And you can see that sometimes the differences are 25 points. So the next slide, I think that it is important to highlight that the information environment itself keeps changing faster than public health can adapt. So if you're taking it historically, in 2018, social media gave everyone a voice. Pro and anti-vaccine content competed mostly through text, images, shared personal stories. In the pandemic era, things have started to change, and the platforms accelerated the spread. Algorithmic feeds amplifying predominantly emotionally charged context, regardless of accuracy. And now, as we stand in 26, this generative AI adds synthetic video, cloned expert voices, personalized chatbot style misinformation that is genuinely harder to distinguish from legitimate sources. So, of course, the positive vaccination content is also growing in volume and reach, but the anti-vaccine messaging tends to be more emotionally resonant, and it keeps resurfacing the same old claims with new circumstantial values. So the next slide and the following one are really factors that erode or protect confidence. And I've put them next to each other because they really mirror images of each other. So we'll start with eroding, yeah? We've talked a little bit about the algorithmic misinformation, the institutional distrust, politicization, those policy inconsistency with rapid contested changes, even well-intentioned one, yeah, read as instability rather than rigor. And then the historical scandals, legacy mistrust, the rare but visible adverse effects, because obviously vaccines are held to a zero harm standard because they're given to healthy people at population scale. And then, of course, the access and convenience barriers. If we go to the next slide, what builds and sustains confidence is almost a mirror, is trusted personal provider relationship. Still the single strongest driver of uptake. The transparent, consistent risk communication. So naming uncertainty and rare risk honestly rather than overselling certainty. That probably is one of the worst things that we can do. The community and peer engagement, so trusted local voices that are carrying more weight than distant institutions, and then stable, depoliticized policies. So visibly positive social norms, seeing vaccination as a common expected choice. Yeah, so convenient, low friction access is obviously part of it, but it's really how people are seeing it rather than just simply the supply and availability. But notice near perfect symmetry. Almost every erosion factor has a direct corresponding protective factor. And that's good news because it means we know where the levers are. And if we can go to the next slide, I think that the messenger matters as much as the message. We already saw the numbers when it comes to the US public trust by institution in 26. Proximity, again, is beating hierarchy, a reversal driven by the perception that federal guidance has become politically contested. And the findings that held over a decade of child's own pediatrician remains parents' single most trusted source for vaccine safety information at 76%, far ahead government experts, family, even celebrities for them. That gap has likely only widened as institutional trust has fallen. So encouragingly, and I say this really truly, a recent Pew survey found that most Americans are still fundamentally confident. So 63% say childhood vaccines are highly effective at preventing serious illness. And while just over half says that they're safe. The floor hasn't collapsed, but it has been tested, of course. So next slide will focus with all this contest on, and we've seen why people hesitate, because what we should do is driven by this particular framework. So the WHO had an original model which was formed by, like 3 legs: confidence, complacency, convenience. Bash and colleagues have refined this into a 5-factor model in 2018 that better explains modern vaccine decision making. So the confidence, the same, trust in the safety and effectiveness of vaccines itself, the systems that delivers it, the motives of the policymakers behind including it into a vaccination schedule, and obviously the trust in science. Complacency, sometimes we haven't seen these diseases, with the vaccination campaigns, even clinicians haven't seen that. And then there is a perceived risk of the disease itself is low, so vaccination doesn't feel necessary. There are the constraints, the structural, psychological barriers, the access, the cost, the time, the hassle, the regular ones, and then the calculation. A part of the population is really deliberately weighing the risks and the benefits, often through active information seeking. And then there are part of us that are actually also looking at collective responsibility, so willingness to vaccinate specifically to protect others through community immunity. So every intervention maps back to one or more of these levers. So going to the next slide, you've seen a lot of graphs in my presentation, and some of them are based on data from the vaccine confidence projects. I want to introduce you to this organization that is really monitoring and, in a way, protecting confidence before it breaks. So the Vaccine Confidence Project was founded in 2010 by Heidi Larson at the London School of Hygiene and Tropical Medicine. And it was in direct response to vaccine rumors and boycotts, including the polio vaccine boycott in northern Nigeria. Maybe some of you remember that. It's now a WHO collaborating center. And the mission is simple, is really to monitor sentiment and trust continuously through surveys, media monitoring, qualitative research. So declining confidence can be spotted and addressed before it disrupts vaccine uptake. Their core tool is the Vaccine Confidence Index, and as I've mentioned, some of the maps included in this presentation are based on that data. Their work hopefully would feed directly into policy. That is a kind of early warning infrastructure we need to have in place to be able to react on time. The next slide is also showing that this is, something that is very strategic, because hesitancy isn't a binary issue, or accept or refuse, is really a continuum. People who accept all vaccines, people who delay or selectively accept and refuse some, and people who refuse all vaccines. And the critical insight is that the largest opportunity sits in the middle of that continuum. The delayers, the partial acceptors, not at either end. The middle group is also the group most responsive to convenient access, a trusted provider conversation, calm messaging. The refuse all group, by contrast, is low demand and low likelihood to change. That's not where the leverage is. And here is where rebuilding confidence at scale requires a number of things working together: the public trust, the demand, but also things like improving understanding of the disease risk, of the vaccine value, equipping clinicians for confident and really good conversations with patients, engaging community and peer voices, and not just institutions, and then an effective coordinative system and the leadership and commitment. So a consistent, unified voice from health officials, from professional societies like the International Society for Vaccines, because a divided message from the top undermines every downstream effort. But individuals can make a difference. We've seen on the hesitancy front, but if we go to the next slide, we can see on science on the front line, genuine human story. And again, I've chosen Baylor College of Medicine because it's there where I started working on vaccines. And Dr. Peter Hotez, after his daughter Rachel was diagnosed with autism, uh, while all this vaccine autism myths, he wrote, vaccine did not cause Rachel's autism in 2018, and that drew him directly into the public debate. But that visibility, while it made him a frequent target of harassment from anti-vaccine and anti-science activists, a cause that he describes very matter-of-factly as part of his job. He's called it, in his words, a disinformation empire doing a lot of damage. But that example is also a call for all of us to be and stay engaged. So practically, what can we do? If we can go to the next slide, I would suggest that there are 6 things that can be done. They're grounded in evidence. So first, lead with empathy before the facts. What's behind a concern, validated, gently correcting a claim without addressing the underlying fear rarely changes any decision. The next one is quite interesting because we could do that much more readily, which is to pre-bunk, not just to debunk. So for instance, use these inoculation messages, warning people about manipulative tactics before they encounter fake news. And that has measurably reduced impact of misinformation across many countries and cultures. So for example, warn people that misinformation will claim you either trust natural immunity or you inject in yourself toxins. Explain that vaccines work while stimulating the body's natural immune response to that particular disease, that type of pre-bunking. I would say state the consensus plainly, so clearly communicate how strongly scientists agree on vaccine effectiveness and safety. And that has been shown to increase public support. If we keep silent or hesitate, that reads as uncertainty. Then the frontliners are the clinicians, so a confident personal recommendation from a provider remains the single stronger predictor of vaccination. So we need to give clinicians the training and the time to engage. The monitoring, we've discussed about it, like the vaccine confidence index. So catch rumors as rumors build months before they become an outbreak. And then treat it as a systems problem. So the 2026 Lancet Commission on Misinformation is explicit on that. Scientists have to partner with behavioral scientists, communicators, and policymakers. Publishing more data alone hasn't reversed any trend. And globally, one more overarching principle. We need to invest in local scientific leadership, research capacity in low and middle income countries, so vaccine science is trusted as homegrown expertise, not as an outside imposition. And then finally, the last slide, 3 takeaways. The first one is hesitancy is not new. It has the same root concerns, safety, choice, distrust of authority, and those have recurred in one form or another since 1721. We are more than 300 years since it all started, and we are still counting. We have a lot of work to do. The second message is that what's genuinely new in 2026 is a speed and scale, is a politicized policies, AI-driven misinformation, and this measles resurgence that outspacing everything we've seen in the last decade as an indicator for what is happening underneath. And the third is the fact that confidence is built locally and personally through trusted clinicians, through consistent messaging, and through resilient systems, is not just through availability of vaccines or innovation. So in conclusion, vaccines don't work on shelves, they work when they are in arms. or orally or whatever, new routes of administration. And getting there in 2026 takes confidence and all of us working together doing our part. So with that, I want to thank you, and I'm happy to take questions. Thank you so much.
Thank you very much, Ruxandra. Thank you. It was a super well done presentation, thoughtful, detailed, and balanced. So now we are moving into the Q&A portion of this webinar. Please, I already received a couple of questions from the audience, but continue to submit your question through the Q&A box that is in this tool. So, but before to go to the the question that I received, I wanted to start with one because you show how the response of different governments and the scientific community can significantly influence public trust and vaccine confidence. Using the example of the HPV vaccine experience, can you expand on why some countries were able to address misinformation and restore confidence relatively quickly, while others experienced a much longer decline in vaccination rates? And what were the lessons that governments and scientists take from those different experiences?
That's a very good question. Thank you all for asking. So as you might remember from my one slide, it is really the speed of response and coming up with the data very clear, not hiding anything, being very precise into the reports. The case of UK, they have not denied that there has been that safety signal, but then they went and looked at what really caused that particular unfortunate death in the schoolgirl, and then immediately put out the information. So it's really the speed of reaction that counted enormously there. Hesitating or taking much longer to respond is what sometimes allows this build-up of hesitancy that is much harder to deal with thereafter. Very interestingly, for Ireland, when finally, the government have realized that the vaccination rates were going down really rapidly, they've put in place a measure which is bring a human face, tell a story, and actually emphasize. By then, there was a lot of data that had been published on the benefits as far as the cervical cancer was concerned and the link with HPV, and then obviously more recently with the head and neck cancers, in particular in males. So all that contributed really to bringing it back. But the more you actually wait at the very beginning, the more it's going to take time on the back end to resolve the issue.
No, thank you for that. And I do think you mentioned during your presentation is not only the messenger, but also the message. And I do think that is important to be built
Absolutely.
from the top, right? So, but thanks for your perspective. So I wanted to go to the question that we receive in the tool. So one is really interesting. It's an anonymous question, but he or she asked, how could restructuring clinical trial design and data sharing build public trust, especially when vaccines mandates risk the damage in that trust?
This is a very good question. Of course, that we really need to take into account the disease. Yeah. So actually looking and actually designing clinical trials that are actually looking at the pathophysiology, looking very clearly at what are going to be the primary endpoints and maybe some secondary and exploratory endpoints are going to help build that body of data that can convince not only the clinicians, not only the regulators, because that ultimately is the goal, but really be able to put forward that information to the general public in a form that is understandable. So really, I would say, look very closely to the pathophysiology of the disease and draft those clinical, design those clinical trials so it addresses not only, like viral load or something like that, but things that actually are meaningful for clinicians and patients.
No, it makes sense. How we can make the very complicated science very simple and plain to be explained to the community. That is critical in my opinion. So from the different perspective, Michael Francis asked you that he is seeing similar trends on the pet side from the veterinary standpoint, because many of the patients that he's helping have doubts to vaccinate their pets. So is there any comment that you have around the same situation being on the other part of the science, which is the animals?
To be very honest, I vaccinate my dog with everything that is available. I cannot give an advice. I'm not really into that field, but because of my general trust in vaccines and because I think that, at least our pets are, in a way, our family members. I am giving them the same type of attention as to any family member.
That's good. Again, an anonymous question said, if you have any comments about the recent executive order of Trump's administration reducing the number of mandatory vaccines and splitting the shots?
So again, I'm not actually debating the number of vaccines and whatnot. From a very practical perspective, if you're looking at the latest executive order and the splitting of the MMR vaccine, we need to remember that there are no, vaccines for measles, mumps, and rubella separately. They haven't been in the United States since, I think, 2008 or so. So it will take some time for that to be implemented. Obviously, we will need an entirely new regulatory pathway, clinical trials, and the expenses linked to that, more vials, more syringes, free doctor visits, free copays, et cetera, et cetera, et cetera. That's a type of a thing that obviously will reduce, even from a very practical perspective, the vaccination rates. So I think that, there are many hurdles to maybe what has been yet again a political statement.
No, I fully agree with you. So Laura Shrimp asked a different question. What are your suggestions for further engaging on the National Immunization Technical Advisory Group and pediatrics, OBGYNs, and Nurse Association as a vocal advocates, considering the political mistrust is also behind hesitancy in countries like Republic of Congo and Cameroon? So is there any idea that you can share with the team, with the people?
So as I've mentioned, professional societies, pediatricians, vaccinologists, will have to put, out their own statements to actually look at data, the scientific data, and what is underpinning that, and come out and support some of maybe counteract this misinformation in a more active manner. If, as I've mentioned in a couple of my slides, keeping silent or hesitating is probably the worst we can do. We really need to be very clear about the value of the health intervention, the public health value, and then really come up with the health economic numbers. I think that, COVID was a very good example. It costed our societies altogether 16 trillion US dollars. Yeah. And as soon as the vaccines were available, everyone wanted to get vaccinated. You remember, it was kind of a frenzy, waiting lists for that. On the top of it, you had developers that worked on treatments that, complemented very well vaccines. But that's the type of economic and impact value that we have to put forward. What is if you have one or more of these diseases that either are resurging or they're coming up, and obviously you need to survey for that, the cost of the society. It's the human cost it's a social economic cost. It's a cost of what built ultimately a part of this mistrust during COVID, which were the mandates. As we didn't have any intervention, the only public health intervention was to make sure that we protect at least those who were, most vulnerable. So it's a complex, I know it's a long, response, and it's a complex issue, but I think that good information is what has to be put out.
No, thank you, Ruxandra. It's very clear. So something that I didn't mention, but it's important for you to know, I received many, many questions, and all the people that are putting their questions unanimously express their gratitude for this excellent presentation. So I wanted to give you the good news. Every people.
Thank you. I really appreciate it. Thank you, everyone.
There is an interesting question here, again, anonymous, that do you have any specific suggestion on what partnership between scientists, behavioral scientists, and communicators and policymakers should look like? I do think it will be very helpful.
Actually, the example of the Vaccine Confidence Project is a very good one. As I've mentioned, Dr. Hardy Larson is a behavioral anthropologist, and she has worked with a lot of vaccine developers when introducing vaccines or even when developing vaccines. Interacting with the behavioral scientists and with the community is essential, not only during the first stages of research, but during the clinical trials, ensuring the buy-in of the communities. But really also looking at what are the local factors that are going to impact the decision to take or not a specific vaccine. For instance, when I had the pleasure of working at the European Commission, we worked with a Vaccine Confidence Project to map the confidence across Europe, and it was used as a tool that shaped some of the vaccine policy. So I think that is essential to start early, to continue engage, and to actually generate the type of data that is not only scientifically viable, but really can speak to the general public.
Thank you again. And I have a question that is super interesting in my view. Peter Openshaw says, do you think the term vaccine hesitancy is the best one to describe the situation that you presented?
I prefer vaccine confidence. To be very honest, and it has been, that balance, the changing balance between the confidence and maybe more on the hesitancy side, that was, that balance shifted to the more negative perceptions as of lately. But I'm very confident that vaccine confidence is a term that we need to use.
No, thank you. And I completely agree with you. That the last question, because we are already almost on time, is a practical one from Tim Alefanis. He basically is looking for your opinion about one tangible way that we as a scientist, clinician, and people who believe in vaccines can engage with our local communities to help improve confidence.
I think that we don't need to be silent again. We really need to reach out. There are many opportunities. There are community gatherings. Many of us are clinicians, so we do engage with patients. I think that clear messaging. I do vividly remember also one year, again, when I was in Europe. We had a very bad flu season, and the European CDC came out with these TV advertisements. They were like little cartoons, and showing how we can protect from flu, how we have to vaccinate, etc., etc. That campaign actually drove up the vaccine uptake by about 20-25%. So really be imaginative in your approaches, because the public is receptive.
Now, again, we are already on time, Ruxandra, but thank you very much for leading such a timely and important presentation and discussion, very productive. And we have like 10 additional questions that we have no time to answer, but the community chat, I'm going to pass the question to you, and maybe you can connect with the people offline. But thank you as well to everyone that joined us today and submitted the questions. So now I'm closing the session, and again, looking forward for the next conversation soon. Thank you.
Thank you so much. Thank you. I really appreciate it. Thank you.